Good evening, everyone, and welcome to our Macular Month webinar. We're focusing tonight on low vision and its impacts on people with obviously low vision, and how you as health professionals can provide services, referrals and support to your patients. My name is Vicky Heaton. I'm Healthcare Relations Manager at Macular Disease Foundation, and I'm also a practicing optometrist in DY, New South Wales. Before we begin, in the spirit of reconciliation, I'd like to take a moment to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islanders peoples today. So I'll quickly run through some housekeeping. All your cameras and microphones have been turned off. If you have any questions, please pop them in the Q&A icon at the bottom of your screen. They'll be answered at the end of the session, but please feel free to type them out at any time. So the webinar tonight has been accredited by Optometry Australia for 1 clinical CPD hour, and the learning objectives are on the screen now. A recording of the webinar will be sent out to you all at the end of the session later in the week, and any links that we talk about we'll send out in that recording as well. So before I introduce our speakers, I have a bit of an ask from you, our health professionals who are working every day with people with macular disease. As many of you would know, the Foundation's work is centred around support and care, and we're conducting research to better understand how we can support more people with macular disease. And we want to understand the views and the opinions of health professionals. So there's a QR code up on the screen. If you'd like to register an interest to participate, that would be really appreciated. We really do believe that the role that you play is crucial to not only the clinical well-being of your patients, but also the general well-being. So it'd be really great to hear from as many of you as possible. And again, that link will go up in the recording that you receive later. So without further ado, I'd like to introduce our presenters. We have Dr. Sharon Oberstein and Lisa Feng joining us tonight. Sharon is a senior lecturer and Nexus Fellow at UNSW School of Optometry and Vision Science, and a senior fellow of the Higher Education Academy in the UK. She qualified as an optometrist in South Africa and graduated with a PhD on driving with central vision loss and bioptic telescopes from UNSW Sydney, for which she was awarded the Menzies Research Scholarship in Allied Health Services. She coordinated, developed and teaches into the Graduate Diploma in Orientation and Mobility. Her advanced skills in low vision have led to contributions to multidisciplinary conferences and low vision rehabilitation planning committees. Also presenting this evening is Lisa Feng. Lisa graduated from the University of New South Wales, Bachelor of Optometry with Honours and Bachelor of Science in 2017. She is therapeutically endorsed and has experience working in both independent and corporate optometry practice in Sydney and regional New South Wales. She is now a lecturer at the School of Optometry, a supervisor at the UNSW Optometry Clinic for the Primary Care and Low Vision Clinic, and also a clinician at the Prince of Wales Diabetes Centre. So welcome to both Sharon and Lisa. Thank you again for being with us this evening, and Lisa, I shall hand over to you now.
And let me unmute myself as well so everyone can hear what I'm going to say for the next 20 minutes. Hello, everyone. My name is Lisa. Thank you for the introduction. And thanks to everyone for joining us tonight on a Monday night to talk about low vision. So it's really exciting to see a lot of disciplines here joining us tonight to talk about low vision and how we can better take care of our patients with low vision. So I'll be going through a bit of kind of general overview of what low vision is, its impact on our patients, some things we can do to help these patients. And then Sharon will go on to talk a bit more about more advanced low vision care, about driving and about bioptic and things like that. Okay, so before we start, or as we're starting, so let's meet Michael. So Michael is a pretty typical patient who we see in our clinic at the University of New South Wales Low Vision Clinic. So Michael is 88, He was referred by Vision Australia, and he's been diagnosed with bilateral age-related macular degeneration and the atrophic type. He is already seeing his ophthalmologist regularly, and he's on all the correct medical treatment. So he's taking Macutech, and he is now retired, but he used to be an electrical engineer. So during history, he noted that the main thing he came into our clinic for was for driving. He is still currently driving with a restricted license, having a condition of 15-kilometer radius, and he was looking to see if there's anything we can do to change that. And also during history, he also mentioned about having difficulty reading and also some concern with crossing the road. So we'll come back to Michael throughout the presentation, and also Sharon will talk a little bit about what we did for him as well. So just to be on the same page about low vision, and I try to keep this talk a bit more general, so hopefully not too many optometry jargon and more fancy words there. But if we're talking about low vision, so what is actually low vision? If you look at the resources and online, there's not actually one clear definition of what low vision and vision impairment is. So depending on where you're looking, so some sources will be defining it based on a visual acuity. So some places will say that it's a visual acuity of worse than 618, and also include some sort of visual field restriction. And then other places will be about 612 to 660, but vision worse than 660, or we'll define them as blind. Other sources are a little bit more general and descriptive. So vision impairment can be defined as any loss of visual function when there's loss of either visual acuity or visual field, or any other visual function. And we'll go through a little bit about that in detail in a second. But in summary, there's really not one definition of what low vision is, but in essence is any loss of a visual function, so particularly the loss of visual acuity and visual field. And it's important to highlight here, it's not something that can be treated or corrected, or it's something after when it's been treated or corrected. So if you have someone with high prescription of myopia or short-sightedness, they're not really considered as being low vision, because if they wear their glasses, their vision is as good as 20/20 or 6/6 vision. So that in itself, it has to be after treatment or correction, and their vision or their visual function is still impaired. The first thing we think about when we're talking about vision is really visual acuity. And that in itself is the ability of the eyes to see a certain size of letter, most commonly, but we do have other visual acuity charts that's set at a certain distance. So pretty much how well someone can read down the chart. So usually we're in the clinic, we'll measure that using a visual acuity chart for both distance and near. And this word acuity chart is something that we use in the low vision clinic a little bit more often, because it's more related to the function of reading or word recognition. Visual acuity is the thing that we refer to and rely upon probably the most, because it's a useful way to categorize the amount of vision loss. So, you can actually define it as mild, moderate, severe, or blind. And again, depending on which resource or which study you look at, the numbers might be a little bit different. Legally blind is something that we do have a definition for. That's when the VA or the visual acuity is worse than 660 in both eyes, or when the visual field is restricted to central 10 degrees, or a combination that leads to one of those definitions. So in a way, we do need some sort of definition for being legally blind, because in Australia, we do need to look at our patients' visual function to decide if they're eligible for any subsidies or government pensions. So that's from a clinician's point of view when we're looking at numbers. But from a patient's point of view, so when their visual acuity is affected, from a patient's point of view, they'll complain more about having difficulty with day-to-day activity. So they won't complain about not being able to see a small writing, a small letter that's black on white. So things they will complain about are being unable to see details far away, like road signs, or being able to recognize the faces of people coming towards them, or at work they can't see the presentation at work, or even looking over the shoulder of their colleague when they're trying to work on something on the computer. up close, so reading any details, so reading either printed materials or also on computers as well. Or day-to-day activities like being able to go shopping to look at the details on food packaging or trying to see the medication bottles and the details on their medication. Visual field is the other aspect of visual function that we rely upon a lot as well. So visual field essentially is the extent, the amount of space that is that's visible to the eye. So typically we'll measure this using degrees. So visual field encompass both the central visual field, so that's what we do and use our macula or our central vision for, but there's also the peripheral vision, which relies on the rest of the eye. And so our total visual field is a combination of fields from both centrally and peripherally from both eyes with some overlap in the middle. So in the clinic, so centrally, we do use our AMSA grid quite often. It's a really quick way to screen for any central visual field defect, but we do have other ways of measuring visual field, so either using a automated perimeter like a Humphreys, or we do have the Sharon screen, which is a little bit more manual as well. Both visual field and also visual acuity relies on the kind of smooth transmission of signal from within the eye, but also along the visual pathway. So through the optic nerve to the back of the eye to the visual cortex. So any condition that's both within the eye, but also anywhere throughout the visual pathway. So any cortical problems like having a stroke or trauma or any tumors along the visual pathway can cause a reduced visual acuity or visual field. Okay. Again, from the patient's perspective, so they'll note things like mobility is probably the one that's noted the most. So getting around, trying to navigate around the world. Oh, sorry for that typo there. So navigating around the world. So particularly, in new environment. And again, depending on where the location of the visual field defect is, especially inferiorly, and if it's a large defect, so they'll actually, note some difficulty with picking up hazards on the floor, and that often leads to increased risk of falls as well, or avoiding people in a crowded environment. Centrally, so if we do have a central visual field defect, so that's more kind of leads to object and also face detection and also recognition as well. And it also does relate to the ability to read smoothly, being able to actually extract meaning when they're reading. So patients often complain about not being able to read smoothly, so they can pick up letters or words, but they can't actually get it into a sentence, or just losing their places or skipping lines when they're reading. Driving is something we'll talk about in a second with Sharon in a bit more detail. Contrast sensitivity. So this is something that's not done as commonly in the primary care optometry practice, but it's something we heavily rely upon in the low vision setting. So contrast is it's essentially the difference in luminance, so how dark or how light something is of an object from its background. So then someone's contrast sensitivity is the ability to kind of detect objects from its background, especially when there isn't a clear or defined border. So someone with reduced contrast sensitivity, their vision will appear more washed out. So in the clinic, we use the Mars contrast sensitivity chart. It actually gives us a number value, which then we can compare to age-matched norm to see if the contrast sensitivity is reduced. So from the patient's perspective, because it relies upon their ability to pick up edges, so things like being able to see the edges of gutters, to see steps, or seeing the hazards on the pavement or uneven pavement. So patients do, it does really lead to an increased risk of falls and fractures, especially in our elderly patients. And it does relate to a change in posture and gait in these patients as well. Particularly when the lighting is poor, that's when contrast is a little bit more obvious. So when it's at nighttime or when the weather condition isn't great, so when it's foggy or rainy. And it also does relate to reading performance in patients as well. So particularly printed material when there's like a gray or color background. So that's why patients will notice a bit more with like newspapers, but also reading food packagings when it's in a different color or even activities in everyday life, like being able to see what's on your plate. And we had a patient recently who was very astute in noticing that her vision's changed, even though her high contrast visual acuity will still remain quite good. And that's because she's noticed she used to be able to cut against the grain when she's cooking meat, but she can no longer actually see meat. And that in itself was indication enough to do contrast. And sure enough, contrast was reduced, and we did refer her to her ophthalmologist. Other symptoms, which I won't go into too much detail, so things like color vision defects. So this can be both from congenital and also acquired eye conditions, and also other conditions too. But again, I won't go into too much details. Glare sensitivity is something that's often kind of noted as well. So struggling to see in the presence of bright light, or being really bothered to see bright light reflected off shiny surfaces. Light dark adaptation is when it takes quite a long time to have trouble, or taking a very long time to adapt to the changing lighting when we go from indoors to outdoors, or going from outdoors to indoors. Say, for example, when they're done hanging their laundry outside and then come back indoors, takes quite a while for their eyes to adjust. And lastly, we do have a lot of patients complaining about visual fatigue. So patients with low vision do often note more visual fatigue and sooner, especially after performing any visual task. So they won't be they know that they can't work for as long or concentrate for as long, either in front of the computer or when they're doing a long drive and they need to take more regular breaks. So here is a list of essentially what we do in the low vision clinic. And the only thing I kind of didn't really highlight in too much detail is a low vision history, which sometimes we do a telehealth for the day before just to save time. But beside the history, we go through visual acuity, we do reading, and we also check the patient for fluency as well, because again, it's more than just letter recognition. We do visual field, contrast sensitivity, and also refraction as well. So both for distance and also for near, where we actually calculate if they need any high add. And we trial any low vision aid and train them to use these low vision aid. We do still do some form of ocular health assessment as well. And also lastly, very important, we're trying to maintain good communication to any of their health practitioners. Okay, coming back to Michael with AMD. So as you can see here, his vision 660 in the one eye, 624 in the other eye, so it is reduced. And the thing to highlight here is that a good tip is if you look at his near VA, so with normal room lighting and his reading glasses, it was achieving N16, which is, yes, is a bit reduced. But when we actually remeasure those, that again with spotlighting or task lighting, his vision improved quite a bit. So that's a good hint that his contrast is probably affecting his visual acuity, especially up close. And also it's a good hint that later on when we're prescribing things to actually recommend increased lighting for reading. So you can see here the numbers for contrast is a bit reduced, and we try to refract him, but he didn't have any significant script to warrant updating his glasses. So his visual field, definitely important to do because of macular degeneration. So fortunately, he didn't have any massive scotomas, so those kind of wavy lines. So he noted them being distorted, but they were also paracentral, so around the central vision, but not right on the visual central vision. And fortunately, his binocular estimate, his peripheral visual field was excellent. It was full, which probably explains why he doesn't really have any trouble with mobility and getting around. And also the back of the eye confirms the age-related macular degeneration. Okay, so with vision rehabilitation, so ultimately the goal is to improve these patients' quality of life. And we want to teach them to optimize the use of whatever's left of their vision after correction and medical treatment. So I want to be able to either correct them with optical aids, or to teach them skills to improve their visual function to perform daily tasks. Something again I didn't really highlight in this talk is the need to support these patients both from an emotional and also psychological point of view as well, for them to adapt to their permanent vision loss. And lastly, the goal is really for them to continue being independent, and also stay actively participating in society. Okay, low vision aids. So the first thing and the primary thing we do is to magnify things, to make things bigger. And that's either with any high plus reading glasses or high plus low vision magnifiers to make it bigger. The thing that everyone probably have in their pocket is a phone, and this is something a lot of our patients picked up themselves, is to be able to use the phone, to use the camera function to capture and shoot. So use the camera to take a picture of something, or just even when something's moving around to actually zoom in using the phone. And this is something they're very open to because they don't really want to bring out their bulky magnifier. Once they've learned to use the phone, it's quite easy to kind of learn and use and carry around. Assistive technology, and this doesn't have to be just electronic. So assistive technology is technically any equipment or any technology that can help to do things that can't be done because of their disability, or to help them perform any tasks a bit easier. So technically a cane or even a bioptic telescope is considered an assistive technology. Again, the phone is probably the one that's most accessible, as they don't need to purchase like a new product. And a lot of phones these days have quite a lot of accessibility features, and also a lot of kind of smartphone apps are tailored and catered towards low vision as well. There are specific computer programs out there as well, which we sometimes do refer our patients to get training on. And also the last thing is for people who struggle with seeing kind of printed material, things now can be kind of made electronically. So, if they're having trouble with reading newspapers or books or even, their bills, to get them done electronically, it's much easier to make it bigger, especially when they have a big screen, but also it's much easier to make it bolder as well. I won't go into any explanation here, but here's some of the kind of newer, fancy assisted technology things. So either like a text reader, or here in the middle, you have a camera, which actually takes a picture and projects a magnifier into a headset. Okay, contrast. So when there is a problem with contrast sensitivity, so either we can increase contrast by increasing the amount of light that is on the task, or we can make the task itself more in contrast or making it bolder. So lighting is something we do kind of recommend quite often in the clinic. So very task focused lighting, but also making things, again, electronics makes it much easier to be increased in contrast. Sometimes if it is glare that causes contrast sensitivity issues, so patients with glare sensitivity, then recommending kind of UV shields and sunglasses will help reduce the glare and also improve contrast. And lastly, it's about educating the patient on when to avoid low contrast environment, especially if there is a risk with falls and safety. So to avoid, going to a new environment when it's nighttime, or to reduce the driving when the lighting or the weather condition is not great. I won't go into too much detail here, but there are some other fancier things that you can kind of do that's not non-optical. Okay, and then again, just to put the slide in here, before visual field defect, there are actually low vision aids that can expand the field loss as well. Okay, and coming back to our patient Michael, so what we ended up doing for him, it was quite simple and straightforward, but he walked away pretty happy. So he continued to wear his reading glasses, which is about a +5 add, and we told him to use his smartphone along with his reading glasses. We just increased the font a bit, and also taught him to magnify things using his camera. He already purchased a handheld magnifier from Vision Australia, so about 4 times. And the good thing about this magnifier is that it does come handheld on a stand, and also it does have a light inbuilt in it as well, which he enjoyed. And lastly, we did reinforce the importance of for him to go back and seeing his ophthalmologist at least once a year, because he was starting to be a bit reluctant in going back to seeing them because he felt like they weren't really making a difference. I didn't really touch upon the driving, but Sharon will go through that in a second. Okay, and the last thing to mention here is to do with kind of thinking about supporting them funding, and also finding out any other services that can help your patient. You want to save a bit of time at the end of your consult, because we don't want to spend all our time showing them all these fancy equipments and teaching them how to use it, only to find out that these equipments cost quite a bit of money and they can't afford it. So I work in New South Wales, and but a lot of these are quite equal across the board. So yeah, to think about how to support your patient in terms of getting funding for them financially, and also other services that can help them, say, to work or do their everyday life a bit better. Yeah, and that's the last bit of my slide.
Thanks, Lisa. So I'm going to take over from Lisa. I'm just going to take over sharing the slides. Yeah, that's great. Thank you. And I'm sharing with sound, yes, because I actually have a few videos that I'm going to play later. Great. So thank you, Lisa, for that. So when what I'm going to try and do in my presentation is talk a little bit more about advanced care, which I'll tell you a little bit more about, driving by optic telescopes, and taking that to a place where understanding access to service and that we can't work alone. And that's why we're all in this room together. So what I love about the ocular multidisciplinary low vision clinic is we're all with O's, but I specifically want to, and this is not comprehensive, this list, but I specifically want to discuss a little bit about the other list, which are not only family and friends, but also the internet, and is becoming more and more important. Facebook groups, even, influencers give support, and some of that support needs to be managed by us. But the growing wealth of information not only through Dr. Google, but through the MDFA, for example, site. And also I just helped launch Seaway, which is also an online site. And if anyone was there, I used one or two of these slides. So bear with me if there's a little bit of repetition. What I love about that, and I shared the slide, so what I love about this concept of all of us in the room and being able to help people that have got a disability or are struggling, is this concept of working together and working with other disciplines. And sometimes we need to look at things in a different way. So I love this photograph by Andres Hemp, which is of the lioness holding something in its mouth. But when you actually have a look at what it's holding its cub. And that's really the message that Lisa and I both want to bring today, is this concept of low access to service and low vision service. And sometimes it means referral, and sometimes it means helping someone in a slightly different way. So this, I was part of a working group with Sharon Bentley. And what we did was we adapted the American Academy of Ophthalmology's smart sight model, which has 4 levels. And for everyone in the room, I'm hoping that you'll be able to go, yes, that's what I'm doing. And just the awareness that, yes, that's what I'm doing, or this is what I'm going to be doing, we can really realize, number one, that we're actually providing low vision services, and number 2, increase that awareness and increase access of service for all our patients dealing with vision loss. So level 1 is simply to recognize and respond. So you're already doing some low vision service. If you realize that whether you're an optometrist, ophthalmologist, or orthoptist working in a low vision clinic, not working in a low vision clinic, occupational therapist working in an allied health field, realizing that that person has a vision loss, recognizing it, and then most probably referring, because you can't actually respond. You can't, treat them yourself. The next level, level 2, is, and this is mostly from an eye care practitioner's perspective, but I think it can be applied to all perspectives, where you start to do simple interventions. And those simple interventions might be giving glare filters, just like Lisa explained, low power magnifiers, lighting, all the electronic stuff that Lisa explained with your mobile phone. Some of those early access to service is at level 2. Level 3 is that more comprehensive low vision service. And that's something that Lisa and I do at the UNSW optometry clinic, where we prescribe a more advanced low vision aids, like bioptic telescopes. And because when I was discussing with Vicky what we should discuss in this webinar, I think that there's less awareness of bioptic telescopes, and that's why I'm going to be talking a little bit more about that towards the end of the presentation. And the last level, so that's level 3, like the UNSW low vision clinic. At at that clinic, we have special equipment. We have special magnifiers. We always use a trial frame to test. We test more in functional space. And then the last level 4, is a multidisciplinary clinic, and that clinic looks more like clinics that would be at Vision Australia, or we have a joint venture clinic that we run at Guide Dogs between UNSW and Guide Dogs. And what that clinic, that has a more comprehensive low vision assessment with more disciplines. So now we get on to the question about, can I drive? So driving is based on the Assessing Fitness to Drive guidelines, and we're going to share with you that it's very easy to Google it, but we will also share with you that link if you want to look it up yourself. And I continually look it up to make sure of certain things. So on that concept of the multidisciplinary, looking at things in a different way and using different disciplines. So firstly, we always have to remember the GP or the doctor in the team, and the doctor, because of the comorbidities, and also they have to sign off on the general health of the patient. Then it's the ophthalmologist or optometrist that might be, well, according to the Assessing Fitness to Drive, might be called upon to actually make a verdict about someone's fitness to drive. Specifically in New South Wales, we used to be able to walk into the driving licensing authority to have your eyes tested. That's no longer. It's now become the responsibility of the optometrists to do that work and submit online. You may anyone who has submitted those online forms or is familiar with Assessing Fitness to Drive guidelines will know about this concept of sending someone for a practical driving assessment. Now, while this is a brilliant tool for assessing processing, and it's actually a brilliant tool in research, the Assessing Fitness to Drive guideline does not support a practical on-road driving assessment for a vision disability. In other words, we have to actually assess vision in a different way. The reason they say this is because someone might do a drive where the vision, for example, if they've lost visual field, nothing will come in their way, and therefore it's not a good way of testing someone to be safe to drive if they have a vision impairment. So what is the next step? And the next step is what I'm saying is, so I've put a trial frame there to represent the low vision assessment. So if someone has a vision impairment, well, they could be sent for a low vision assessment to assess whether they could drive, or their optometrist could do that work, or their ophthalmologist, banking it on the Assessing Fitness to Drive, what is written in the Assessing Fitness to Drive guidelines, because that's evidence-based. This is what the Assessing Fitness to Drive guidelines is. It's this document. There's a link you can Google it, and most of the document's quite extensive. It's about 10 conditions, vision conditions, 10 medical conditions. The only one that we really need to worry about is number 10, which is vision and eye disorders. And that's the one we need to worry about in detail. Now, it's divided into 3 sections. And the third section is the actual guidelines. What do those guidelines look like? I've put the detail onto the slide. I'm not going to go through it in detail, but 612 is the cutoff acuity for an unconditional driver's license. And I'd just like to flag that in the assessing guidelines, it says that 624 is the cutoff. No license will be given if the vision's worse than 624 for a conditional license. So we do have leeway. And then there's a visual field criteria as well, which I'm not going to go into today because we're dealing more with central vision loss from macular concept with the MDFA today. So that looking at that high contrast visual acuity, some little things that I would like to flag: you must have 5 letters on the chart. And failure is more than 2 errors on those 5 letters. And then you can give a conditional license as long as the vision's not worse than 624. As far as visual field goes, I'd like to just briefly say that is run on confrontation test as a screening tool. With any problems, you should be doing a binocular estimate or equivalent test, which screens. It's a screening test. It's not a threshold. And what I did want to flag today was, if you can see, it's a bit small, probably on your screens, but this particular field test that I've given you an example of, there were no errors. However, the person saw the point. However, this test is not valid because there are more than 20% false positives. So you must check that the test is reliable. Right, so those visual clinical measures that are, to recap on that, that are written in the Assessing Fitness to Drive guidelines are your high contrast visual acuity and your visual field. But very important is contrast sensitivity, which Lisa already told you about. And now what I'm going to do is apply some of the things that Lisa told you about to goals, because we're always goal focused in a low vision assessment. So that's why we're talking about our patient who came in that wanted to drive and his other things that we could help him with, but it has to be goal focused. So there's contrast sensitivity is something that's very, very useful when helping people that have vision loss, and we test every low vision patient, we test their contrast. It answers a lot of questions, helps us guide the patient, but there are also a lot of other visual clinical measures that are important for driving. And so I've listed them on the screen, but I'm not going to go into them in too much detail. I'm putting the slide back up again, even though I kind of mentioned it, that there are a lot of non-visual important things to remember when talking about driving. And what I particularly want to flag here is that you have to ask your patients about their driving task, because the Assessing Fitness to Drive talks about it, and their driving experience. Have they had crashes and accidents? And what is the driving task that they want to drive? And hopefully this will become more clear as I talk about it. But all those things and more are very important. And yes, the driverless and auto and cars and all the features in the modern cars are really making this that much easier for people to consider driving when they have loss. However, right now, we still need to make sure that people are safe to drive according to the Assessing Fitness to Drive guidelines or the evidence research that's around. All right, so instead of going to the same patient we spoke about earlier, I'm going to give you another patient. We have another male today. I should have made one a lady, but so Ben is 83 years old. He also has AMD, and he's had cataract removal. He's also under his care of his ophthalmologist, and he's on supplements. His driving task, as I said to you, because this is what I wanted to illustrate in this case, is that he wants to drive to the local shops 3 times a week. That's what he wants to do. He doesn't really want to drive at night. And he's been driving for 60 years. So some of that experience has to come into our conversations with no accidents or citation in the last 10 years. It's not that I just quoted the last 10 years because that's what we could remember. So it wasn't that he had an accident before that. So now we apply our clinical results. Much of the results that Lisa discussed with you, yes, we do a trial frame refraction, and we found that his best visual acuity on his right eye is 615, and both eyes, I didn't put that in there, sorry, both eyes is 615. So, and his Mars contrast sensitivity, 1.52. So this is a different case to the case that Lisa showed you earlier. But his visual field, that one is reliable and it's all intact. His confrontation test is all intact. Okay, so here are our, just before we revisit this, I wanted to just talk to you about how we interpret contrast sensitivity. What we do there is we interpret the contrast sensitivity according to the age-matched normal values of your test. So we use, as Lisa said, the Mars Perceptrix test, and it comes with norms. And that's what I would really be recommending, that the test you use, because you can get tests on projectors, but you have to equate it with norms, and it's really insightful into the functioning of a person's vision. So on this test, over 60 is 1.52 to 1.76. You'll remember that he had 1.52 contrast sensitivity, so it's just within the norms. But what I did want to say is the research has shown that poor contrast sensitivity due to cataract, and that was also the case that Lisa showed you about, were shown to be 6 times more likely to have a crash. And really a flag for me is a 1.25 contrast sensitivity. That's a real flag for driving. So let's go back to the outcome of Ben. Does Ben's visual acuity meet the requirement for an unconditional driver's license? If you remember, his best vision with both eyes was 615. So no. So we can actually say to him, you don't meet the requirements for an unconditional license. Is it within the normal range? I've showed you that. And yes, he's 83 years old and he's 1.52 borderline. His left eye is a flag. So the next question I ask you is, does Ben's visual acuity meet the requirement for a conditional driver's license? And if so, what are his conditions? Important to remember here is his driving history and his driving task. So, and then we'll talk about some other recommendations. So firstly, I'm telling you that yes, with 615 vision, I was happy to support a conditional driver's license for him, conditional on spectacles, no night driving, and periodic review. Why periodic review? Because he's got a progressive eye disease, and you're going to see what happens as we see him a few more times. Oh, by the way, always other recommendations, because we want to start planning their rehabilitation, conversations about driving cessation, about the prognosis of the disease, and also falls prevention and extra lighting, which I think we've really explained to you today. So we saw Ben 18 months later. He's now 85. His ophthalmologist tells us in a letter that he has extensive dry AMD, and his vision now has dropped out to 619 in the right eye and 619, sorry, in both eyes. I should have put the both eyes on there. And the Mars has dropped again, 1.36. It's now outside of normal values. He reports that he is driving a bit less, but he's still driving. He's had no accidents in this time. So, wow, we gave him a driver's license with 615 VA, and he's been fine. Now he's 619. And I actually said, yes, okay, we'll give you another conditional license because he still meets the criteria with spectacles, no night driving, again, no night driving. Also, his contrast has dropped. Periodic review, of course, we keep that on there. And he actually has restricted his driving to 15 kilometers from home. That's his driving task. But also in New South Wales, drivers over the age of 85 can choose between having a 15-kilometer restricted license or having a on-road driving assessment. And we again are discussing his driving and falls prevention. And that's what his eyes looked like a year later. And now he's actually stopped driving. So his VA with both eyes there is 630. His contrast has dropped to 1.12 with both eyes. So what I want you to consider here is that we have given him 3 years of driving, and he had no crashes. And this is, you know, he didn't have any crashes. We made a big difference to his life. So this brings me to talk about delivering bad news. And some little hints, always be honest, obviously, but obviously be compassionate. We try and avoid medical jargon, but at the same time, use your signs and symptoms when you're giving bad news. And if someone is struggling with what you have to say, it's always nice to say, have you got someone to speak to? And of course, referral. When you give bad news, I've used the SPIKES protocol. It really makes sense to me. And the most important thing is the setup. Don't have these conversations when you're in a busy waiting room or in a busy room. It needs to be quiet. It needs to be private. And most importantly, try this, sit down. The patient should sit down and you should sit down. It's so much calming. Remembering, understanding the patient's perceptions, inviting them, asking them questions, what they want more information about, giving them the knowledge without too much jargon, and then the emotions of the patients, and then always, which I'm going to talk more about, and then always sum up. And my sum up statement often is that what you expected to hear? So the psychological adaptations to vision loss is something that Lisa touched on, and I'm going to go quite quickly here because of time, but this is adapted from Elizabeth Kubler-Ross's model for terminally ill patients. And it's worth remembering that when you give someone bad news, even if you followed everything in the SPIKES protocol, they may not be at a place where they can accept with what they've got. And these stages are not sequential. They not necessarily sequential, but and it's okay to go through all of them. It's okay to be a bit angry. It's okay to bargain. But you have to we have to support our patients to move forward. Especially, there was a study done that especially in vision, the first 2 years, that's where they manifest their low acceptance and often high in denial to that loss. So that's a flag for you. Okay, so now we're going to move on to what is a bioptic telescope. And if you have vision worse than 624, can I drive? And Lisa and I have had some fun with AI, and we got an AI to generate us an image, and it didn't know what a bioptic telescope was. So many of you may not. So I've actually got a video here, which I will share, that tells you what a monocular telescope is there and what a bioptic telescope is.
Individuals with central vision loss will struggle to discern details on signs from far away. When a monocular telescope is used, the user must come to a stop and raise the monocular telescope to the eye. They will locate the object and focus the telescope on that object. Only then will they be able to view a magnified view of the sign. The user can now read the detail of the sign as it is magnified. The monocular telescope can't be used while moving, so timing can be a problem. Having to stop and align the telescope can cause a delay. This might mean that a moving object needed to be seen might pass by before the magnified image is located. A bioptic telescope can be used while moving. A bioptic telescope is a spectacle-mounted telescope. The telescope is usually mounted at the top of conventional spectacle lenses. Most of the time, the user views the world around them through the carrier or conventional spectacle lenses. When required, the telescope is aligned momentarily by dropping the chin for 1 to 2 seconds to align the telescope and view a magnified image of the sign. The sign becomes larger. The chin is then lifted. The user returns to viewing through the spectacle lens and can continue walking. Their motion is not disturbed. Bioptic telescopes can also be used while driving. The telescope is aligned momentarily by dropping the chin for 1 to 2 seconds to align the telescope and view a magnified image of the sign. The chin is then lifted, and the user returns to viewing through their spectacle lens. This movement of glancing into the telescope momentarily is much like the action of glancing into the rear view mirror of a car. In this way, bioptic telescopes can be used to identify detail on signs from farther away than without the telescope, and is beneficial for driving.
So, but there are bioptic telescope driving programs established in America, Canada, and the Netherlands. What about Australia? Well, bioptic telescopes are not included in the standards, but it does say in the Assessing Fitness to Drive guidelines that an assessment can be performed by an ophthalmologist or optometrist when making licensing decisions, and recommendations can be made. Very important is that there needs to be training done. I've got a picture there of someone having the assessment first, then there's on-foot training, like by an orientation and mobility specialist, and then there's hours and hours of behind the wheel driving. And I've got a quick video to show you of that. Now, what you'll see is if you look in the rear view mirror of this video, you'll see the person use their telescope. So the sound is not great, so I'll repeat what he's saying. So he's driving along and he's not using the telescope. And then now he's going to tell us that he sees a red light ahead. Green light, sorry. And now the driving instructor says, is it an arrow or a circle? And he uses the telescope. And he knew it was an arrow. So it might be hard to see that, but that is what that's how the bioptic telescope is used, only for 1 second to identify that it was an arrow. So let's go back to Michael. Can Michael drive? If you remember, his vision was 624. His contrast sensitivity with both eyes together was 1.4. We prescribed a 6x Ocutec bioptic telescope. In the left eye, he can get 69.5 minus 1. And we have actually given him a conditional driver's license, no night driving, and restricted to 15 kilometers. And that 15 kilometer he actually has done because of his age as well. But he's still driving. So in summary, some of the things that Lisa and I have tried to talk to you about today is definitely a low vision has to be goal focused, a specific focus, whether it's reading, whether, as Lisa said, whether it's a newspaper, or whether they want to read online, or whether it's specifically driving. Teamwork is very important. I discussed that approach. Then we have special equipment, and this my little joke says, very good, now let's try it from back there. We do start close and we want them to achieve, and then we move them further away. You'll see some of the visual acuities that we gave were 3 meters, and then we push them to 6 meters. And we also use special charts for near as well, like Lisa said. We do our refraction in a trial frame in free space. A lot of our things we do in free space, rather than using too many machines in our low vision assessment. Then we do special things, DIS and travel passes, or electronic magnification and special magnifiers. Then as far as driving goes, what we do is based on the Assessing Fitness to Drive guidelines, although the work I showed you with bioptic telescopes is something that I did my PhD in, and I'm with that work, I'm ready to push the 624 boundary. But with someone who's not working at that level 3 low vision clinic, with all those special equipment and special trials for bioptic telescopes, probably wouldn't do that work, and that's okay. You know, we can't all do everything, and that's the bioptic telescope that I do in advanced care work. And I hope that was useful. Thank you. So I'm going to stop sharing and have a look at if we've got any questions.
Thank you so much, Lisa and Sharon. That was a really, really wonderful presentation. You've really highlighted the importance of how we think about our low vision patients, and also, you know, all the things that can be achieved by referring into the services. So just a reminder now, if you could add your questions into the Q&A section at the bottom. I'm going to just do a quick run through of just some MDFA things while you are putting your questions in. So let me just share my screen. Okay, so we do basically, we have quite a few supports for patients with MDFA. We've got a lot of resources. We've got a lot of sort of little short bite videos on the website, booklets, and some pre-recorded patient webinars as well. So the QR code on the screen will take you to our resource page, which I've put vision loss in. So it's filtered through, and you can see basically lots and lots of things for yourselves and your patients to access. Little bit on iConnect, so hopefully most of you have heard of that by now. It's our support service for people with AMD, age-related macular degeneration. One of the key pillars in iConnect is the practical advice, and that's where we can certainly reinforce your referrals to low vision services. And the team are also always there with the emotional side of things on the phone calls and being able to talk to patients, as Sharon and Lisa have both mentioned. It's really a large part of the low vision journey for people. And the other thing is health literacy that iConnect provides as well. I'm just going to give you a super quick update on how to refer. So it's quite straightforward. You can refer patients through Oculo. There's just a drop-down menu with Macular Disease Foundation. MDFA website, we've got a referral form, and we've got paper referrals as well that you can order from us, and we can shoot them out to the clinic free of charge for you. So we are very excited to let you know that we've got more than 600 people in iConnect now. So we're supporting a lot of people out there. A massive thank you to you all for your referrals so far. And diabetes journey is coming soon as well. So look out for that in 2025. And we're also launching new nutrition guidelines, CPD. So you'll be able to learn all about the research and the evidence behind our nutrition guidelines. And I think it's really great to know for yourselves, but also to pass on to your patients. So I shall stop sharing now and let's go on to some questions.
So I can start having a look at some of those questions. I've put a few little quick answers into the chat. So someone has asked about amblyopia. Can that be considered as low vision criteria? So I was saying yes, of course. If the vision cannot be compensated by spectacles or contact lenses, then yes. I'm busy writing as I go. Then that is most definitely. There was a question. No, there is. If someone asked about contrast sensitivity and conditional licensing, there's tons of evidence to show that that high contrast visual acuity is not a good predictive driving performance, but contrast sensitivity is. But contrast sensitivity is not included in the guidelines. The information today was quite applicable to Australia-wide. I apologize if we got some things specific for New South Wales, but most of the Assessing Fitness to Drive guidelines, for example, that's nationwide. The definitions we gave you about low vision, that's nationwide. I'm thinking what other questions, Lisa, are there any in there that you would
Yeah,
like?
sure, if you wanted to jump in, I would love to answer everyone's question. Seems like we actually have a lot of interest in this area, which is great. So I think someone asked if an optometrist should start the ball rolling for applying for my aged care and DIS when they're referring a patient. I think, yeah, that's up to you, depending on how much time you have in your clinic, because I do understand that, you know, a lot of consults, you don't have a lot of time to do all these advanced care. We try to leave the ball in the patient's kind of, you know, let the patients decide as well. So the best thing that you can do as an optometrist is also to provide as much information from an eye perspective and also from a function perspective. And a lot of times you do have to involve other people in the care as well. So in the case of NDIS, a lot of times you do need to have an ophthalmologist sign off when they're applying for NDIS as well. And in the case of my aged care as well, a lot of these patients do go through the GP to get a holistic assessment as well. So either way, you can start the process, or you can also involve the other people, and then ultimately the patient can also sign up themselves as well.
And then
I think,
I'll add, sorry,
yeah,
Lisa, and then what I'll add there about the NDIS is that our patients often don't know about it. So often they come in and they don't know that they might meet the criteria. So someone asked about the vision criteria. There are 2 criteria to register with the NDIS. And if you go, you can actually go and have a look at these online. The first criteria is legally blind, which Lisa told you about. The second criteria is list B conditions. And list B conditions actually gives conditions like albinism, which have got multi-sensory problems. Even Stargardt's is on there. So you don't have to be legally blind to reach that criteria. And then as far as aged care goes, it's also, if you have to have a permanent disability, and that you have to write a report. So again, the same applies as far as I'm concerned, because we managed to get that a device prescribed on aged care. But it is person by person.
Sharon, can I just quickly ask, is that an
sure.
Lisa mentioned it's an ophthalmologist that has to sign off, is that correct for so that isn't done by optometry or GP if vision is involved?
So the reason why they want an ophthalmologist, they do for NDIS, is because they want prognosis. I'm not sure that it's necessary in the safe space, I can say, but the reason is that if, for example, someone has a cataract, they don't want to register someone with NDIS because they want their cataract to be treated. So yes, they do require an ophthalmologist evidence of diagnosis.
Mm-hmm.
Yes. Which other questions do we answer?
I think we have a lot of driving and bioptic questions.
We do. So the one about commercial driver's license, you know, that's a tricky one. We did get someone with a commercial driver's license. The biggest thing is we have to put conditions on the license. So I have to say there's not a lot of research in this space. Right now, we're really working with a private driver's license, not a conditional driver's license. And when a person came to see me that was a taxi driver, the one thing about it is they've got so much experience, but definitely not buses, and no, because even commercial licenses are even stricter than private driver's license.
Another one is, can an optometrist sign off on a conditional license? It doesn't need to be an ophthalmologist.
Absolutely, big time. An optometrist actually has more time to do those extra tests. Have a look at the Assessing Fitness to Drive guidelines. Don't do anything you're not comfortable with. You could say to a person, you don't meet the criteria for an unconditional driver's license, but you might meet the criteria for conditional license, and, you know, send to one of your colleagues. And I always give my students the example that if I was going to do ortho-K, if someone asked me to do an ortho-K, I would send to a colleague, because I don't do ortho-K. So that's not, if you don't have contrast sensitivity or you're not comfortable, you don't have to do anything. You just have to be able to tell your patients. You have to give them the right advice.
There's a couple on the vision limit needed. So when do you start to recommend it, or is there a minimum vision limit for the bioptic telescopes?
So not the max, so not the worst. You mean just when it's, so in Australia, you can drive with vision up to 624 on a conditional license without a bioptic telescope. In the US, from 612, they start recommending a bioptic telescope, and we do offer all patients with vision that doesn't meet the criteria for an unconditional license a bioptic telescope. If someone asks me, I did show you the wording, The states all differ with regards to bioptic telescopes. There was a question saying that they don't sound safe, and I hear you, but I think you need to look at the evidence and know that there are bioptic telescopes have been used since 1970. I went to America and I got trained. Training's important, proper assessment's important. All those other measures of visual acuity, contrast sensitivity, glare, all of those things are vitally important. But when all those boxes are ticked, it is quite amazing. The people with just central vision loss actually compensate very well. They can see the car, or cars, they can see the dog running in the field, they can see the child. And so you have to look at the evidence is what I have to say to that one. And we've seen amazing outcomes, and people, and there's evidence is two ways. Evidence is from practice and evidence is from research studies. So there's two ways to look at it, and you just have to look at the practice. People have been driving with bioptics telescopes with vision as worse as 660, even worse than that, in the US since 1970. Very interesting. Yep. Yeah, is there anything else?
I think just one good one is that other than UNSW Low Vision
Oh.
Clinic, where
Yeah, I was just typing away at that question.
Ah.
So Vision Australia or Guide Dogs, if you and they're usually in one in every state, and also for universities with optometry, so then they would also have their own low vision clinic as well. Anything to add, Sharon?
No, brilliant. And there are a couple private optoms as well that do work in the low vision space.
Yes, true.
Super is to reach out to like the Macular Disease Foundation as well. Oh, someone asked about psychosocial, and that's where I was going to link in with the work that the MDFA do, just acknowledging the amazing work that they do. Like all my AMD patients, I refer them there because they can get good, solid advice and resources. And I also wanted to point you in the direction of Seaway, which is a new site in with guide dogs that links to the Macular Disease Foundation, for example. That's what I love about all these organizations, that they work together. And on Seaway, they've got an arm for psychosocial as well. And you can actually get some psychosocial therapy, that's not the word I'm looking for, but you can actually get some psychological help through that that's a new launch because there was a need. So yes, you can get those services.
I think we're just about running out of time. Were there any other questions that you wanted to pick out, or is that it for the evening?
Someone said Vision Australia provides level 4 services, and I agree. And that's why I think it's so important for us to understand that level 4 services, we can all do something. Every one of us can do some level of service, and then we can send to other people.
And we do. You're right, Sharon. If a patient calls our helpline, we've got a list of all these sort of in different states and territories and locations. We've got, we can provide information on the closest and most local level 4 services for patients too. Yeah. So I think we might have to call it an evening. Thank you both so much. It's been a really, really wonderful presentation. People have been asking for low vision for quite a long time, so it's really great to be bringing it to such a great, diverse community that we've had online tonight. So thank you all. Thank you all for being with us this evening. As I said earlier, I will send out all the information in an email. We'll follow in the next couple of days with any links. And I'll just say thank you again and good evening.
Thank you.
Thank you, everybody.
Thanks for coming.
Bye.